Hi, I'm Dr. Megan Gilman. I'm an assistant professor of psychiatry and behavioral sciences at Duke University and the medical director of the Duke Oncopsychiatry Clinic. And I'm going to be presenting with our team today on addressing barriers to cancer care in patients with SMI. I have no disclosures with respect to the following presentation. So when we talk about SMI or serious mental illness, we're referring to primary psychotic disorders, including schizophrenia and schizoaffective disorder, and primary mood disorders, including bipolar disorder and severe major depressive disorder. With regards to cancer diagnoses, there is not necessarily an increase in incidence in patients who have a diagnosis of SMI, but what we do see is a significant increase in mortality for patients diagnosed with SMI and subsequently diagnosed with cancer. Mortality rates are increased even in the first 5 years post-cancer diagnosis. And if you look at the chart on the right, you'll see a significant increase in mortality, particularly in patients with a diagnosis of schizophrenia. I'm going to talk about three cases of patients with an SMI diagnosis, and we can consider the course of their cancer care and some of the challenges that were faced and overcome. So the first case is patient J. J was a 19-year-old male with metastatic testicular cancer. He was admitted medically after a scheduled surveillance scan identified pulmonary findings suggestive of metastasis. While he was admitted medically to the hospital, he was noted to be responding to internal stimuli. His symptoms persisted and worsened over the course of the admission. He demonstrated increasing paranoia, was complaining of distressing auditory hallucinations, and did start to demonstrate some aggressive behaviors, particularly towards his primary caregiver, but also towards some of the medical providers coming in the room with some posturing and being verbally aggressive. At that point, the cancer treatment, which was intended to be continued chemotherapy and subsequent radiation therapy, the plan was actually put on hold. This was done in order initially to assess for whether or not the chemotherapy that had been started was actually what was causing the psychotic symptoms, and the patient was discharged to home. In another case, patient H, this is a 56-year-old female with a long history of schizoaffective disorder, and her psychotic symptoms and mood symptoms had been very well controlled for the previous 10 years on a long-acting injectable. In fact, the only physician that this patient had come into contact with in the past decade was the general psychiatrist that she was seeing monthly for administration of the LAI. She presented to the emergency department complaining of chest pain. There was no documented history of any health screenings, and she did not have a primary care physician. What was identified on exam was a large sanguineous breast mass that had actually ruptured the skin in the left axilla and was causing considerable pain for this patient. And the third case that I wanted to introduce is patient D. D was a 31-year-old female. She was married. She had two young children at home. She had been diagnosed with a high-risk breast cancer. The treatment plan, because the cancer was high risk, was time dependent. There was a certain urgency to getting through all aspects of the treatment. And Dee tolerated the double mastectomy and recovery from that. She tolerated chemotherapy and was then scheduled to start radiation therapy. Dee actually had an episode of acute agitation in the waiting room outside of the radiation suite. She was loud, she was aggressive, she was endorsing suicidal and homicidal ideations, and she unfortunately could not be de-escalated, and security had to be called. She was escorted to the emergency room and was subsequently admitted to an acute inpatient psychiatric unit. On the acute unit, collateral information was obtained that did reveal a history of type 1 bipolar disorder that her husband admitted he had not revealed previously because he was worried that the patient would not get her cancer treatment um, if there were concerns about her mental health. So, when we think about what barriers there are to care for patients like J and H and D, there's sort of four main categories of things that we run into. One is non-adherence, which both to psychiatric treatment and to complicated and busy chemotherapy, surgery, radiation schedules, complicated medication regimens for oncologic care that can be very difficult to manage. There are also interactions between oncologic interventions and psychiatric treatments, including risk of QT prolongation in combination, psychiatric antipsychotics in combination with medications like methadone for pain control or antiemetics, or even some chemotherapies or immunotherapies. Um, and the question of which medication takes priority can become a complicated one. Sometimes one of the things that we see with patients with SMI is they sometimes actually present with already advanced cancer at the time of diagnosis. And this can be the result of psychiatric symptoms actually overshadowing the cancer symptoms in the initial presentations for care. So patients that are presenting with what might be perceived as anxiety, but ends up being related to an actual respiratory issue due to a lung mass, or patients presenting with worsening psychosis or mood symptoms that in fact end up being due to a brain tumor. And so we do see later stages of disease at time of diagnosis. And then there's also physician frustration and communication issues between the patients with SMI and their oncologic providers. Patients with SMI have a higher rate of involvement in known risk factors for developing cancer, things like obesity, alcohol use, and cigarette smoking. There's also very poor adherence to health screening. So, for example, women with schizophrenia are 5 times less likely to have adequate cervical cancer screening than women without a diagnosis of schizophrenia or other SMI. Women with a low severity mood disorder are 7% less likely to ever have a mammogram than women without a mood disorder, whereas women with high severity mood disorders are 66% less likely to get a mammogram. And so this is why we do see this later stage of cancer at time of diagnosis. The complicated treatment plans that are asked of these patients are further complicated by the severity of the disease that the oncologists are now trying to treat. So, in thinking about how best to address these barriers, from the role of the psychiatrist, there needs to really be like a constant engagement in reassessing the specific medications and dosages that are needed to maintain psychiatric stability. And so this becomes sometimes a negotiation where a patient requires a medication for their oncologic treatment or supportive management during oncology treatment, and being flexible and thinking about how to adjust the role of the psychiatric medication so that those symptoms can continue to be addressed, but without interacting with the necessary cancer treatment. Capacity assessments by psychiatry can be incredibly important at major transition points in cancer treatment plans. So, particularly around surgical interventions, there's some evidence that patients with SMI diagnoses are less likely to have surgical interventions for cancer diagnoses, particularly lung cancer. And while this may be that they are also more likely to have metastatic disease at the time of presentation, there's also concern on the part of the surgeons as to like how the outcome can be ensured when the course might be more complicated in the setting of ongoing psychiatric issues. And so a formal capacity assessment prior to a surgery or prior to the initiation of a new treatment can be very reassuring to the oncology providers that the patient is capable of and aware of what they're agreeing to and capable of moving forward. In our role as psychiatrists, sometimes patients are not do not have primary care doctors, are not sort of seeing other people for general health management. And so, even before cancer diagnosis, checking in with patients like about regular appropriate health screening, including mammograms, pap smears, and colonoscopies. And most importantly, in our CL role is really facilitating communication between primary care, oncology, and the patient support network. It really is a team effort, cancer treatment in general, but particularly for patients who face the challenges of ongoing psychiatric issues, making sure that everyone is communicating, everyone has all of the information, and working with oncology providers to simplify these complex treatment plans. So the more that we can combine office visits, scans, scheduled blood draws, combine treatments with interactions with the psychiatry team, for example, so that there's a constant check-in, it can be very helpful. So just to think about these three cases, with patient J, he was ultimately diagnosed with schizophrenia. This was felt to have been a first episode psychotic episode. He was stabilized on risperidone. And what we did was schedule outpatient psychiatric follow-up to coincide with radiation treatment. So I was actually going to the radiation suite and seeing him there. And so this was both reassuring to Jay, but also to the oncology team because I could see him in that setting and reassure everyone that he was capable of moving forward with this necessary treatment. And once he finished his active cancer treatment, we did transfer his care to a general psychiatrist in the community who was better suited for managing the schizophrenia itself. For patient H, unfortunately, her disease was so advanced at the time of diagnosis that there was no treatment available, but we did connect her with palliative care and we were able to get home hospice services that continued to administer her Haldol decanoate so that her psychiatric symptoms could remain well controlled through end of life. And patient D was ultimately stabilized on a mood stabilizer and an antipsychotic, but immediately upon discharge from inpatient psych, discontinued her medications and decompensated. She had to be readmitted to psychiatry, which again was further delaying the timely treatment for her high-risk breast cancer. And so we arranged to have her transferred to a med psych unit where we were able to keep her psychiatric symptoms under control with daily medications, but she could be moved to the radiation suite each day for the concurrent radiation treatments, which she was able to complete. So the takeaway here is really just the broader role of the psychiatrist in the care of SMI patients with SMI and a cancer diagnosis. And so paying attention to health maintenance and adherence to treatment, being flexible in adjusting psychiatric treatments to accommodate the necessary cancer treatments and supportive therapies. And advocacy, really being an advocate for a patient that we know can be lost in the system and have poor outcomes as a result of their psychiatric diagnosis. So, communication with the full team and advocating for this patient to move forward with treatments that they are capable of tolerating. Thanks so much. And Dr. Mukherji will now present the next part.
Thank you, Dr. Gilman. Let me just share my screen. Okay. One moment. All My name is Shamik Mukherji, and I'll be talking about consent and assent. Do they matter in the oncology setting? Just make sure my microphone is on. Good. I'm the director of the Consultation-Liaison Psychiatry Fellowship Program over at Zucker Hospital, which is part of Northwell Health. And I'm also a outpatient psycho-oncologist in the R.J. Zuckerberg Cancer Center. And I have nothing to disclose. So the loss of medical decision-making capacity is very common in cancer. Up to 1/3 of oncology patients may lack capacity to participate in research studies. Up to 1/4 of neuro-onc patients may lack capacity to consent to neurosurgery. And over half of patients with brain mets show some degree of incapacity. When someone is incapacitated, it's not always a given that they start to refuse treatment, however. And in most cases, assent along with surrogate consent may suffice in continuing care. And I've highlighted the differences between assent and consent here. In general, while consent is the agreement to an intervention that is informed by understanding and rational discourse, the CUAR model from Applebaum and Tenzi and others, assent is short of that, where a person may not demonstrate full capacity to understand an intervention, but agrees to participate in it anyway. Consent is legally binding, but however, assent is not. We often get called for capacity evaluations in cancer settings, and at what point does incapacity count or matter in cancer care? For instance, screening tests may be non or minimally invasive, but the immediate benefits may be distant, and on the sliding scale of ethical adjudication of capacity evaluation, given the lack of emergence, the bar for capacity may be low. For diagnoses, biopsies, and scans, the situation may be growing more dire, and the degree of coerciveness that the intervention may need still may be low. So we often may say that a person may lack capacity to refuse a biopsy or a scan in the short term. However, in treatment, there may be difficulties in assessing or even consistency of assessment, as many interventions require routine acquiescence to care that is spread out over long periods of time. And that includes palliative care as well. So for the liaison psychiatrist, it is important to be vigilant about who is at risk of incapacity. Neurocognitive deficits, overall frailty, disease burden, active psychosis, the lack of healthcare literacy, and the distrust of healthcare are all correlated with number one, SMI, and number two, with eventual difficulties with the decision-making capacity. In general, healthcare literacy is associated with issues of decision-making capacity and may have downstream effects on quality of life, navigation of treatment, health services, medication adherence, and as illustrated in this combined synthesis map from a mixed studies systematic review, in healthcare literacy may be or lack thereof may be associated with higher unmet information needs. You don't know how to ask good questions if you don't know how or feel empowered enough to even ask those questions to begin with. In short, you don't know what you don't know. In a study of 122 patients with lung cancer of various stages and types, overall 23% of patients were found to lack decision-making capacity over major decisions regarding their care. The factors associated with incapacity in this particular study were neurocognitive deficits, overall frailty as measured by the VAS-13, and polypharmacy. Interestingly, in this study, age was not correlated with incapacity. As a counterpoint, in this study, SMI was not a predictor of incapacity, even though non-SMI patients were found to be overall sicker and closer to end of life, which may have somewhat confounded the outcome, which the study writers did acknowledge. This is our usual decision tree on how we approach capacity assessment, right? We first try to determine if a patient has or had, in a binary fashion, does patient lack or have capacity, but furthermore, is the intervention emergent in nature? Can capacity be restored in time? And is this thing that we want the patient to do even executable over objection anyway? We usually get called here, where the binary question of whether or not a patient has capacity is posed. However, as per the sliding scale model, the degree of emergence, the ability for capacity to restore, and the feasibility, of course, of treatment are also factors employed to fully determine the capacity query. I argue that monitoring for decisional capacity and maintenance of stability in SMI patients may require a proactive approach where we can intercede rather here in the middle of the process as well. In this situation, our role, as echoed by Megan's presentation as well, may be in the proactive monitoring of active psychiatric symptoms, and thus the proactive monitoring of capacity as well, which would necessitate close work with oncologists, patients, and their surrogates. This may require a shared decision-making model between the oncologist, patients, and surrogates. And in other disease models, such as diabetes, shared appointments or near scheduled appointments in a co-located care model has been shown to have direct benefits to medical care and adherence. And as I mentioned, healthcare literacy is a major factor in capacity. So in our vulnerable patients, it may behoove us to take part in a degree of healthcare-related education, almost in a primary care model, as Megan mentioned as well. Particularly with SMI or high-risk patients, persons who may at risk of losing capacity. Finally, for reasons I'll illustrate, it may be important for us to be proactively involved in encouraging patients to complete advanced care directives for their care in the use for future incapacity as well. These are the factors that interfere with the restoration of capacity to begin with: the chronic nature of a mental illness, the degree of neurocognitive decline, patients who are interred in a state psychiatric hospital who have chronic, difficult to abate mental illness, non-compliance with psychiatric treatment, a history of distrust in medical context, which often is the case of SMI patients, and of course, judicially defined incompetence. For instance, something that would be posited by a guardianship. Another rate-limiting step of capacity determination or evaluation may also be the logistic, ethical, and legal feasibility in forcing a patient to do something that we want them to do, even if they were incapacitated anyway. So this begs the question: what medical interventions are executable over objection anyway? Right? This what is the juice worth the squeeze? This involves a discussion about the degree of coercion involved. Will this thing, say we want to do chemotherapy or radiation therapy against someone's will? Will this involve physical restraints, chemical restraints? How repetitive would this intervention be anyway? Usually, chemotherapy and radiation therapy are not sufficed to do once, right? The degree of expected benefit of the intervention, of course, may be thought of as well, right? Is this curative? Is it actually life prolonging? Is it definitive in nature? Is the degree of coercion that we're making the patient go through worth the actual expected benefit of the intervention? These are questions that we should ask ourselves, but also ask of the surrogate decision maker. I'll go over some cases of forced chemotherapy and forced cancer care. This has been most publicized in the case of minors. So, for instance, these are two cases where children who opted to refuse chemotherapy were compelled by the state to undergo chemo, both actually against the guardian's wishes as well. There were some limitations to the search of these things, as in adults, the decisions around chemotherapy mandates are often trial level decisions that are not formally reported or published outside of state or county specific dockets. So the search that I've done using Google Scholar, but also LexisNexis and Westlaw, which are large legal case databases, may not be fully exhaustive. In this study, in this case of the superintendent of Belchertown State School versus Joseph Sekowitz, the patient was a 67-year-old male who was chronically intellectually disabled, who was residing chronically in a DOMH school. The patient had leukemia, And whereas normally it would be assumed that the patient, would want life-prolonging illness, the physicians and guardian both argued that chemotherapy would not be in the patient's best interest. Um, the judge and appellate agreed that forcing chemotherapy itself would be technically infeasible given the patient's chronically agitated nature, and forced care would not would increase the risk of other proximate medical harm. For instance, strapping him down would increase the risk of aspiration pneumonia. Chemotherapy would cause intolerable side effects, and it would be less than 1 year of expected benefit to the patient anyway. Um, so ultimately, it was ruled that the patient would not be forced to undergo chemotherapy, and would be allowed to die peacefully. The patient did eventually succumb to his illness within a little over a year. In most cases of children, however, guardians cannot withhold life-saving care. However, so that begs the question, what is the duty and limits of the power of the surrogate when the patient is an incapacitated adult? In a case where a patient made a decision about his healthcare where he had capacity and then lost it, which was the case of the matter of Eichner, the courts did allow the refusals of care to continue. However, in a more famous case, the matter of Storer in New York in 1981, the patient's mother was the guardian. The patient had severe intellectual disabilities, and the mother wanted to withhold blood transfusions for a patient who had chronic leukemia. The appellate court overruled the guardian and emphasized a high evidentiary bar, that clear and convincing evidence for omitting or not foregoing life-sustaining measures would have to be met in order to not give a patient life-sustaining measures, assuming that the patient is essentially a vulnerable patient. This represents a concept called parens patriae, where the state has some interest to the patient above the needs of the surrogate, even in this case. This case highlights the importance of the documentation of advanced directives where it is possible, though in the matter of Storer, it was not possible anyway. When can courts mandate chemotherapy and radiation therapy? Well, they can possibly mandate, though this varies wildly from state to state and from jurisdiction to jurisdiction. They can mandate when the patient lacks capacity to refuse cancer care, if the patient is actively refusing this cancer care, and no prior refusal exists when the patient did have capacity. They can do so when less intrusive efforts are not available. For instance, if a immunotherapy that's purely oral can be provided, and less invasive chemotherapy or radiation therapy can be avoided, that may be the better avenue. Coercion, and finally, coercion, if allowed, must be limited and regularly reviewed by multiple parties, including the healthcare surrogate. Key takeaways are that logistic, ethical, and legal barriers are present to compelling a patient to undergo cancer care. Assent along with the consent from surrogate decision makers is okay in proceeding with care. Refusal of care, if aligned with advanced directives, is okay, and we must weigh the logistic feasibility of actually doing the thing with the expectation of benefits. Guardian authority is not unlimited, and coercive measures may require, especially if they're done on a regular basis and not a one-time basis, may require judicial authorization, which varies from state to state and from case to case wildly. This would allow us to have a holistic approach to the whole spectrum of capacity determination and the whole spectrum of what happens to a patient after the capacity is determined. And we argue a proactive approach that allows our intervention at multiple stages along this spectrum as well. Thank you. And our next speaker will be Dr. Daniel Vener. I will stop sharing my slides.
All right. So I will be going next. My name is Dr. Khan. Dr. Vener will go right after me. I'm just going to share my screen. Uh, all right. So thank you again, Dr. Mukherjee, for that important talk. So for my presentation, I want to shift gears a little bit and talk about the psychiatric effects of existing cancer treatments as seen in the literature, especially in patients with severe mental illness. So my name is Dr. Wajiha Khan. I am a CL psychiatrist at North Shore University Hospital. I have no disclosures. So as we know, cancer research is always evolving, and now we have several breakthrough treatments for different types of malignancies, including immunotherapy and targeted therapies. So for this talk, I wanted to specifically explore the psychiatric impact of treatments such as immune checkpoint inhibitors, CAR T cell therapy, antibody drug conjugates, tyrosine kinase inhibitors, and monoclonal antibodies, as opposed to the more conventional treatments like surgery or chemotherapy and radiation. Um, so the question I was hoping to find more information about is how these novel treatments can potentially trigger or exacerbate psychiatric symptoms, including psychosis and delirium in these patients. And why is this research important? And I just want to go over some numbers that I found. So evidence demonstrates that individuals with severe mental illness, just in general, have higher mortality rates from cancer than the general population. Individuals with severe mental illness, particularly bipolar disorder and schizophrenia, have 2 to 4 times greater mortality from breast, lung, colorectal, and oral cancers compared with adults without any mental illness. It is proposed that inequities in cancer care may lead to premature mortality. And given the significant data, those with severe mental illness are facing an immense disparity in cancer treatment. And it's important to try to understand these potential barriers and how we can make meaningful steps to challenge this. Um, Unfortunately, even though this is a very important topic to explore, when I was doing my research for this presentation, in looking at the supporting literature, I found that although neuropsychiatric complications have been reported, there is very limited data on the psychiatric effects of these newer oncological therapeutics. So just transitioning to some of the data that I did find, and I want to take some time to briefly go over it. First, I wanted to talk about CAR T cell therapy. So one systematic review looked at psychiatric effects, specifically associated with CAR T cell therapy, which was published in 2022. It found that cognitive impairment followed by mood symptoms were the most common psychiatric side effects associated with the treatment. It also showed just a significant decline in the quality of life in these patients. And it did acknowledge that it's unclear if the side effects were from the targeted therapy itself or from cytokine release syndrome or neurotoxicity. Another systematic review, a little more recent, it was published in the Journal for Immunotherapy of Cancer in 2024, looked at CAR T cell therapy side effects as well, and it found that the most frequent neuropsychological symptoms were aphasia, attention deficits, impaired consciousness, and confusion. It also showed that early intervention strategies, including using like corticosteroids, could potentially reduce the intensity of the neuropsychological symptoms, prevent their progression to critical complications. Another type of treatment I looked at was the psychiatric impact of immune checkpoint inhibitors. So a study published in 2023 looked at the psychiatric adverse events associated with the use of these immune checkpoint inhibitors. And it found that psychiatric adverse events accounted for 2.7% of the reports. And among these, confusional states was the highest, with 17.09%, followed by insomnia, anxiety, depression, and then delirium. The median time of onset of these adverse events was within 30 days of starting the immune checkpoint inhibitor treatments, and the median age of the reports was about 70 years old. It found that the odds of the psychiatric adverse events was higher in older populations. And all right, and then finally, I wanted to go over a few case reports that I found as well that examine the psychiatric effects of specific treatments. I will specifically look at 4 different cases. All right, so in particular, psychosis has been mentioned with the use of sunitinib, which is an oral multi-targeted tyrosine kinase inhibitor used for the treatment of renal cell carcinoma. All right. So this study that I'm looking at for case 1 was published in 2011. It describes this case of a 78-year-old female with metastatic renal cell cancer and history of bipolar disorder with depressive episodes. And this diagnosis dated back to over 20 years. And the study mentioned that it was under control and stable with medical therapy. She was on amitriptyline, propranolol, and lansoprazole, which were her home medications. So in this case, the patient underwent radical nephrectomy for clear renal cell carcinoma of the left kidney in 2008. Unfortunately, 1 year later, she was found to have bilateral lung metastases and ultimately initiated on sunitinib. On her second cycle of sunitinib, she experienced several side effects, developed gastritis, esophagitis with bleeding, and ultimately was admitted to the hospital because of the bleeding. At this point, the sunitinib was suspended. Uh, the patient then developed acute psychosis while under treatment. This was interestingly 3 days after being admitted for gastritis. And the 3 days after the sunitinib was already stopped. She was noted to be confused, disoriented, and this progressed to becoming overtly psychotic with visual hallucinations and aggressive behavior. She was diagnosed with acute psychosis of uncertain origin, prescribed Haldol 5 to 10 milligrams PRN with no benefit, and the psychotic symptoms continued for 4 days and eventually subsided. She was discharged without antipsychotic medications, and given the toxicity that she experienced with this medication, the sunitinib treatment was ultimately stopped for her. What was interesting about this case was that the psychotic symptoms resolved spontaneously 7 days after the drug was initially discontinued. The authors were looking at, is there a possible causal relationship? And they proposed that a possible mechanism of action of why this may have occurred and why the psychotic effects presented 3 whole days after the drug was discontinued was first, she was taking propranolol, which, as a CYP3A4 inhibitor, possibly increased the plasma levels of sunitinib, which led to the toxicity. The other hypothesis was that sunitinib has a very prolonged half-life and it takes about 8 to 12 days to fully clear it, so it could still trigger symptoms even after it was stopped. So another article, also published in 2011, also looked at the same drug, sunitinib, and it described 2 different cases of psychotic symptoms as well. So the first one is a 62-year-old man. He also had clear cell renal carcinoma, started with sunitinib 50 milligrams daily, and then eventually developed visual and auditory hallucinations 10 days later. The sunitinib was discontinued. He was treated with Haldol 1 milligram twice a day. His hallucinations resolved completely after 48 hours. Unfortunately, because the tumor was progressing very rapidly, sunitinib was not restarted in this case. The second case was a 63-year-old man, also with clear cell renal carcinoma, who's treated with sunitinib 50 milligrams daily. 18 months later, psychotic symptoms occurred with paranoid delusions, visual disturbances. He was also treated with Haldol, this time Haldol 2 milligrams twice a day, which was replaced with risperidone 2 milligrams daily. Sunitinib was also discontinued when he developed these symptoms, and uh, the psychotic symptoms improved 5 days after discontinuation. He was eventually restarted on a lower dose of sunitinib. 10 days later, he was continued on risperidone and remained free of any psychiatric symptoms. So, and in this case, which was different than the other two, co-administration of antipsychotics allowed for the continued use of sunitinib without any further problems. Uh, this case report also tried to look at what the possible pathophysiology is of why this medication is contributing to the psychiatric effects and the psychosis. And what it focused on was the fact that sunitinib is a vascular endothelial growth factor receptor inhibitor. It crosses the blood-brain barrier and it affects angiogenesis, vessel permeability in the brain, which can then cause localized brain dysfunction, can lead to cerebral inflammation and edema, or it can also cause decreased blood flow, leading to these neuropsychiatric symptoms. What was also interesting was that the case discussed that the VEGF, vascular endothelial growth factor, levels are decreased in the prefrontal cortex of patients with schizophrenia, and antipsychotics actually increase the levels of VEGF. So sunitinib may actually cause psychosis in a way that's very similar to what is observed in schizophrenia with its inhibition of the receptors. The last case I'm going to talk about is psychosis that developed with the treatment of sorafenib. Sorafenib is a multi-kinase inhibitor. It targets RAF kinase, vascular endothelial growth factor receptor, and platelet-derived growth factor. This case in particular was looking at the BASIL trial, which was combining sorafenib with BA869766. It was a new selective MEK1/2 inhibitor in the treatment of liver cancer. So even though, just a side note before I go on, even though sorafenib was combined with this trial drug, the authors of the case report proposed that sorafenib alone was what was contributing to the psychotic symptoms that eventually developed because, like sunitinib, it is also a vascular endothelial growth factor receptor inhibitor. So the case describes a 72-year-old man with diabetes, chronic Hep B, no previous psychiatric history, no family history of neuropsychiatric illness, who was receiving this combination therapy. In the 9th week, he started developing insomnia, visual disturbances. He felt that the size and the shape and the locations of different objects he saw in the room were distorted or changing. He also thought they were persecutory. He had persecutory delusions of thieves in his house. Both the trial drugs were withheld, and the neuropsychiatric symptoms, including the insomnia, they remitted without any antipsychotic use in 3 days. 1 month later, the trial drug was re-administered. This time, he started developing symptoms in week 5, again with insomnia, visual disturbances, auditory hallucinations, again, same persecutory delusions of thieves coming into his house. The patient was referred to a psychiatrist 3 days later because there was some conflict with the family going on because of these delusions. Once again, the trial drugs were withheld. The symptoms diminished gradually over 2 to 3 weeks. Antipsychotics were not administered because of side effects. There's also a stigma associated with it, so the family did not want to go through with that. Unfortunately, in this case, the tumor did progress and the patient passed due to pneumonia with respiratory failure associated with lung metastases. And as mentioned earlier, the authors felt like the biggest reason for the effects was involvement of the vascular endothelial growth factor receptor inhibition. They also talked about changes in the downstream ERK pathway, but they stated that there needs to be more research on the effects of this with this medication. Okay, so I guess when thinking about the four case reports that I mentioned, what I found interesting that of the four cases, only one of them had a patient with a psychiatric diagnosis, which was the first case with sunitinib, with the woman who had bipolar disorder. And even though she carried that diagnosis, it was emphasized that her psychiatric condition was very stable. The other cases had no psychiatric history. While it's understandable that this was highlighted to show that the sunitinib or the sorafenib combo that I mentioned can cause psychiatric manifestations, um, even if there's no pre-existing risk, at the same time, it highlights that perhaps one of the bigger issues here is that those with severe mental illness just may be entirely excluded from new medication trials, which limits their access to it. So as mentioned before, I guess I'm going back to here, inequities in cancer care can lead to premature mortality, and it could very much be that the barriers to actual trial participation or the exclusion criteria from trials is what's contributing to this disparity. One study in 2024 examined the frequency and the nature of this exclusion criteria for patients with psychiatric disorders in a large sample of early phase oncology clinical trials. And it looked at 117 protocols and the exclusion criteria related to the psychiatric disorders. The drugs that were most commonly studied were immune checkpoint inhibitors, tyrosine kinase inhibitors, and bispecific antibodies. What they found was a majority of the ongoing studies, 114 or 97.4%, featured at least one criterion that could exclude patients with a psychiatric illness. They classified the exclusion criteria in four different clusters. Cluster A was any psychiatric disorder not specified. Cluster B talked about specific psychiatric diagnoses like bipolar disorder, depression, or substance use disorder. Cluster C talked about pharmacological concerns and the potential interactions with psychiatric drugs. Cluster D was exclusion based on clinician judgment. And the example that they gave is history or evidence of any other clinically significant disorder, condition, or disease that, in the opinion of the investigator or medical monitor, if consulted, would pose a risk to subject safety or interfere with the study evaluation procedures or completion. And astoundingly, cluster D was the most prevalent, 96.6% falling into that category, followed by cluster C, cluster A, and then cluster B. As a side note, within cluster B, substance use disorder was the most frequently mentioned psychiatric disorder. And in cluster C, which was the pharmacologic concerns, QT prolongation was mentioned the most. So the conclusion of the study was that nearly all the examined trial protocols contained at least one criteria that could result in the exclusion of patients with severe mental illness. And this was most commonly based on subjective clinical judgment. So this creates a discussion that there would be a real benefit to enhancing this subjective clinical judgment. And as mentioned before, with tools for evaluating consent capacity, possibly to reduce bias on the decision to exclude these patients. All right, so in conclusion, some of the takeaway points, how can CL psychiatrists help in the situation? And I think the first step is recognizing that there are significant disparities in cancer care. Patients with severe mental illness should safely and equitably be included in innovative cancer treatments. CL psychiatrists can help identify patients who may actually be suitable candidates for oncological clinical trials. They can help manage potential interactions between psychiatric medications and cancer treatment. They can also collaborate in assessing mental health status of patients during these trials, can provide meaningful insight into the impact of cancer treatments in individuals with severe mental illness, which, as I found through this research, we ultimately need a lot more data for. All right, so these were my references, and thank you so much. And now I will hand it over to Dr. Vener. Thank you.
Thank you very much. Let me get my screen up here. All right. I'll be rounding off our presentations, sort of carrying through a topic that has been discussed in the first three, addressing practical and ethical dilemmas in end-of-life care for patients with serious mental illness. I have no disclosures. Biggest goals to get today for this section of the presentation is going to be briefly touching on some of the practical challenges, which you'll notice being very similar to the challenges in the care of patients, what they experience at the end of life. And then we'll also talk a little bit about some of the ethical challenges of managing these individuals, specifically through the lens of psychosis and suicidality. So talking a little bit about the significance, SMI is going to affect a whole range of ways that people approach the end of their life. I've highlighted a few of them here. Prognosis and illness severity, as has already been demonstrated. Individuals with SMI are more likely to present sicker and die earlier, so they've increased morbidity and mortality than their healthy counterparts. Patient values are going to be different. They may be more idiosyncratic due to longstanding SMI, and how they want to approach the end of their life might be informed by that. So also the social context. So it's not just how these individuals interact with their illness and how they present with their illness, but also how does the healthcare system interact with them in their specific social context, whether that be because individuals are unhoused or have financial insecurities that are related to their SMI. And then lastly, decision-making capacity. And clearly decision-making capacity is been a through line through all of these presentations. But one of the realities is that SMI does affect decision-making capacity, especially as we get towards the end of life. And we can talk a little bit more detail about that as we get into the ethics discussion. So the practical challenges are going to be very similar at the end of life to what they were during the whole course of care, but come to a bit more of an acute point in certain respects. And we're going to go through four of what could be multiple other topics, specifically access, lack of integration, specifically between psychiatric and palliative care, concern for management of how do we take care of these patients who are psychiatrically ill but are dying, and then the environment and the ways that the individual's environment is going to affect how they access care. So people with SMI are going to not receive as much chemotherapy. They are going to be treated less than individuals who do not have SMI. They're less likely to engage with palliative services, both hospice and both for hospice care and for palliative care. And then they're going to be experiencing greater morbidity and mortality from the same conditions. So already we know that access for the care part of it is going to be harder, but also for once they reach the end of life, their ability to engage with those services that will allow them to have a dignified end of their lives might be more compromised. There's a lack of integration between the psychiatric and palliative care services. Generally speaking, most palliative care services are linked mostly with somatic medicine rather than psychiatric, which can limit our ability to take care of both. And so people are either sort of shunted into palliative or psychiatric care avenues without either one of those, whether it's psychiatric or palliative, being equipped for the management of the complexities that come up at the end of life. Related to that, individuals with SMI may be more unpredictable or idiosyncratic, which can lead to palliative care settings feeling uncomfortable managing some of their psychiatric symptoms. And then additionally, interactions between palliative medications and psychiatric ones are complex. You'll need to think about how benzodiazepines and opiates might interact with each other, especially towards the end of life, to realize that it's not as simple as having somebody followed by both teams. The environment is also going to be playing a large role here. People with SMI are more likely to be unhoused or have alternative living arrangements like living with family or friends, which can make home care and home hospice more challenging or unfeasible altogether. They there are so on the flip side of that, from people who might have erratic housing, are those individuals with SMI who have spent much of their lives in psychiatric institutions and have come to know them as being almost a second family in some ways. And because these psychiatric institutions may not be equipped to manage the medical burden that happens at the end of life or be able to do things like home hospice, people will have to be removed from their home setting, which leads to the conclusion that oftentimes individuals with SMI are more likely to die in nursing homes than their healthy counterparts. So I just wanted to touch on some of those practical considerations, again, echoing a lot of what's been said by Dr. Gilman, Dr. Mukherji, and Dr. Khan, and dive in a little bit for the ethical challenges that come up. Specifically, I'm going to talk about it through two lenses. One is that of psychosis. Psychosis obviously is going to affect the phenomenological perspective of the individual. And so how they're going to see the world is going to be different, and how the CL psychiatrist is going to be evaluating their decision-making capacity at the end of life is different. And I'm going to highlight specifically autonomy versus non-maleficence as being major areas for consideration with these individuals. And with suicidality, differentiating between suicidality, which is obviously of major concern in SMI, and a desire for hastened death, and navigating that spectrum and the ways that that interacts with autonomy, non-maleficence, and beneficence. So in individuals with psychosis, psychosis itself is not enough to say that a individual lacks decision-making capacity. Somebody can be delusional or have hallucinations and still retain the ability to make important decisions about their care. What I would like to encourage through this is what I'd like to encourage through this, though, is a recognition that as we approach the end of life, our risk reward balance shifts towards risk if we take a more paternalistic stance towards these individuals. So if somebody is refusing a treatment or making decisions that don't necessarily align with what we might want or expect, as they're approaching end of life, it's something that we should perhaps be giving greater leeway to. And this also ties into non-maleficence. The reality is that longstanding psychosis or schizophrenia is not likely to be successfully treated at the very end of life. So we should, whenever possible, try to avoid involuntary hospitalizations, except for when that psychosis is truly presenting acute risk for harm to self or others. Related to that, paternalistic stances towards best interest. Specifically, what I mean by that is forcing people to get treatments that we think might benefit them, and we're worried about that they're refusing. It can lead to some very uncomfortable scenarios, as was highlighted by Dr. Mukherji. We want to be very careful at the end of life with not having an overbearing stance towards these individuals. With suicidality, I want to highlight these three issues of autonomy, non-maleficence, and beneficence. Specifically, that people should be allowed to choose the manner of their death, especially in the context of terminal illness. And one of the issues that comes up here is that because suicidality and desire for hastened death and medical aid in dying all sort of exist along a spectrum, the legal components of this changes the way we think about it from an ethical perspective. In meta ethics, we try to think about these things as being universal in a sense, that what's happening in Georgia is going to be the same thing as what's happening in New York and from an ethical lens, as is happening in Michigan. But we know that legally we are more limited. So what's happening in my state of Michigan is going to be very different than what's happening in Vermont. And so the ethical conversation is somewhat geographically limited. Um, with regards to non-maleficence, again, I want to highlight that involuntary hospitalization at the end of life should be really a last resort. We know that involuntary hospitalization has a relatively lower efficacy in long-term suicide prevention. It's really helpful for that acute phase. And so as we're approaching end of life, unless it's somebody who's going to be actively hurting themselves in a way that we feel is inconsistent with their values, we should be perhaps reconsidering whether or not we need to be pursuing involuntary hospitalization. What we don't want to have happen is people spending the last days or weeks of their life in a psychiatric setting. On the flip side of that, though, is beneficence, which is that the management of depression is something that can happen in palliative settings, and it can really improve quality of life. So we don't want to ignore depression. We just want to be careful about a paternalistic stance towards these individuals. Going on a little bit about the spectrum of suicidality at the end of life, the most critical part of the evaluation is going to be determining whether suicidality is a function of psychopathology or if it's masking some other concern or a patient's value about how they want to approach the end of their life. So obviously we want to be careful about making sure that people have appropriate pain management, whether this is a function of existential despair or financial hardship. And then the ways in which people can have their lives be ended is itself variable and a spectrum. So we have on one side of it the use of opiates or benzodiazepines and helping people feel a sense of relief, which is generally legally and ethically accepted. You know, people can stop treatment when they want. That's also legally and ethically accepted. But as we get towards more active involvement from physicians, it becomes more tenuous. So palliative sedation is legal, but not necessarily something that is ethically easily supported. And then once we get into medical aid in dying or physician-assisted death, this becomes much more ethically controversial and is legal in only certain locations. I want to show here that there is this spectrum, and such that in certain states we are able to offer this in an ethically and legally supported way, but in other states we're not. And so when I was in my fellowship in New York City, and people were asking to be allowed to die and for support in dying, we were encouraged to talk with them about this and to talk about what the realities of it were, but we couldn't even ethically or legally give resources on how they might be allowed to pursue physician-assisted death, unless they had their own knowledge and financial resources to be able to pursue that themselves. It just presents a bit more of a challenge for us in the community on how to communicate with patients about the end of life when we have such variability within our country. One of the really excellent papers that I came across while I was going through this was specifically differentiating between medical aid in dying and suicide. And it pointed out four specific differences between the medical aid in dying and suicide that I think are worth talking about here in the context of end-of-life decisions for people with SMI. Specifically that hastening death when the end of natural life is approaching is not synonymous with suicide, both from a dictionary point of view, like how we actually think about the terminology, but also from the vernacular, how we communicate about it with people. Unlike suicide, medical aid in dying is very collaborative and it involves both physicians and loved ones, whereas suicide tends to be a lonely and isolating experience. The clinical presentation of patients is different from those whose suicidality is driven by psychopathology. Patients with a desire for medical aid in dying tend to approach it from a very rational perspective, whereas suicidality tends to involve irrationality at its core. And then certain behavioral traits differentiate medical aid in dying patients from suicidal ones. Most notably, that depression isn't actually a primary issue for 80% of patients who are pursuing medical aid in dying. In fact, depression exists at basically the same ratio of about 20% for individuals with terminal illness versus those who have a terminal illness and are pursuing medical aid in dying. Here are some of the references that I had, and thank you very much.